Hey, gang, we want to welcome you to today's podcast. We're interviewing Dr. Jason Smithson out of the UK. He's going to spend a little bit of time today talking to us about direct restorations and conservative adhesive dentistry. Jason, thanks so much for joining us today. We really appreciate it.
Hi, it's a real pleasure. How are you?
How's it going over there? Weather good?
I live in Cornwall, which is the extreme west.
Okay.
And it's a peninsula, a little bit like the Cape. And it's normally raining. But we have really nice weather today. We have blue skies, let's say high 60s, which is tropical for us. And you caught me mid-afternoon. I've been in my garden today, cutting trees, which is kind of my hobby. But
don't you run out of trees at some point if you're cutting them down?
No, I've got loads of trees.
We are the opposite. So I'm in North Carolina, and we are about to have a band of really nasty storms come through. So hopefully it doesn't mess up our internet connection or our conversation in the next hour.
Hopefully your roof stays on.
Yeah, exactly. If Chad were on this, who's one of our other co-hosts, if he were on, he always has a Texas terrible storm come through when we do our live broadcast on Wednesday night. It never fails that he'll have a giant hailstorm or tornado at some point during the broadcast in the summer. So
no, we don't get that.
Yeah, fair.
Just rain sideways.
That's right.
Days a year.
That's right. Well, thanks so much for taking time out of your afternoon and from your garden to come talk to us today. Can you give our listeners a little bit about your background, how you got started in this journey of adhesive and direct restorations? Because I think I saw you also did an oral surgery residency as well. So a little bit of how all of this has evolved to now you're an educator and lecturer in that realm.
Yeah, so I qualified at the Royal London Hospital, which is in London, obviously, in 1995. And then my game plan was really to be a prosthodontist. But in the UK, to be a prosthodontist, you have to pass an exam with the Royal College of Surgeons, it's called a fellowship exam. And there's a lot of medicine in that. So it's kind of considered to be the right thing to do a year in oral surgery because it involves more medicine and it helps you get through the exam, which is sensible. So I went from being a dental student and qualified to doing in a London maxillofacial job, really, as a resident. And it was kind of glamorous. You know, I'd gone from filling teeth to seeing people with gunshot wounds and falling off buildings and being helicoptered in. It was what we call a level 1 trauma center. I guess you have the same in the US, which is where the major traumas go.
Right.
So I was like 24 years of age and it seemed like really cool. So, yeah. Right. So my real game plan was to do a year of that, get my fellowship, then go to the US, where I had a place in Michigan, actually, to do my pros, and then come back to the UK and work in private practice, but also work at the Eastman Dental Institute. That was the game plan. But I got waylaid for about 3 years with oral surgery. And then I kind of woke up and after 3 years, they said to me, well, to be a maxillofacial surgeon, you've got to do medicine as well, because in the UK, you have to be doubly qualified in medicine.
Oh, I see.
And I thought, do you know what? I'm not sure I want to spend 3 or 4 years doing medicine or being a student again. So I thought, all right, I'll go into general practice. So, I'll go back to pros. Yeah. So I got in touch with the professors who'd given me the references, and they said, yeah, sure, that can still work. So I got everything keyed up to go to the US. And then I met my wife. So it's kind of a romantic love story, if you will.
There you go.
And I decided I didn't want to go to the US because I just met my wife, or the girl who became my wife and still is my wife, which is lucky because I gave up my pros career.
This would be a love story and then a tragedy all wrapped up in one.
It could have been, yeah. Well, she might tell you it was a tragedy getting married to me, but anyway. So I got all that keyed up, and then I decided not to do it, being hugely decisive as I was. And then I just went into general practice. And I had good mentors in general practice, but it was in the area I'm in now, in the extreme southwest, very, very rural, just doing really quite basic bread and butter dentistry, silver amalgams, extractions, acrylic dentures, et cetera. And then it was kind of the late 90s. Now, you're probably too young to remember, but
no, not.
or you look too young to remember. Let's say that. So there were a lot of American speakers that came to the UK to teach aesthetic dentistry at that point, and we had what was called the aesthetic revolution in England or the UK, whereby a lot of people moved from just doing needs-based dentistry to doing temp veneers on a regular basis. But my patient base wouldn't really stand it financially at that time. So I came back from these classes having learned how to prep temp veneers, having learned how to manage the occlusion, having learned how to temporize, having learned how to bond and maintain them, and presented that to my patients. And I was quite tenacious. I presented it to pretty much everybody who I felt needed it, which in England is everybody. The patients were busy. They couldn't get out of the practice fast enough because the fees were just too high at that point. So after I destroyed half my list, gone elsewhere, it kind of sunk into me that ceramics wasn't going to work in my office at that point. So I found some mainly European teachers actually who did very similar things, but in resin. So, these patients have the same needs, but solving it with resin was, for me, artistically more satisfying because, I was kind of the designer and the creator, and it was all down to me and my assistant, and also it made it financially more accessible for my patients, and so I started doing that, and I was in a practice with a guy called Jeremy Harris, and he was relatively interested in that, but his main interest was implants. So there were just two of us in the office, and it's kind of difficult to bounce things off somebody who's doing something completely different. So I started posting cases. You may remember this. It was a website. Well, it still is, I think, a website called Dental Town. Years ago. Yeah. I think it's still active. I'm not sure.
Yeah.
Not as much as it was.
Right. But it was a really revolutionary platform early on. I mean, as a young dental student, when it kind of came online and a young practicing dentist, we use that tremendously for
education,
for peer-to-peer support, It was nothing short of going to see a patient and then going to Dental Town going, has anyone ever seen this before? Help me figure it out.
Exactly. So to be honest, I was mainly doing it for peer review. I wasn't doing it with any, nowadays a lot of younger dentists post things on Instagram and stuff like that, and the drive is to be an educator.
Right.
I had no interest in being an educator. I just want to know whether I was doing a good job. That was kind of it. And then a guy from Australia, a guy called Lincoln Harris, asked me to do a lecture in Canada. And I was not really a lecturing kind of guy, and I didn't have any IT skills, so I actually said no. And my wife persuaded me to do it, and I did it, and it was kind of okay. And then a few other people asked me, and it just kind of took off from there.
Yeah.
But I was dragged kicking and screaming as a little bit of a bit of a nerdy academic, let's say, into the lecture circuit, and it was just a question of being in the right place at the right time. You know, not that many people were doing stuff with resin. You know, Facebook had just taken off, Dental Town was going, and that gave me good, you know, by default, good promotion, which is not what I was looking for, but it did. And yeah, and here I am now working 3 days a week in an office, private office, fee for service, mainly, well, no, exclusively doing aesthetic and reconstructive with a little bit of removable, mainly implant-based. You know, about a day a week doing legal reports and probably about 100 days a year lecturing. So that's kind of me.
Is your practice still, I mean, it's obviously morphed over time, and it sounds like a more, I don't know if high end is the right word, but more dental high IQ patients coming in and seeking specific services from you. Are you still finding that you're relying more on resins for those types of aesthetic cases, or have you morphed more into porcelains and other type of indirect restorations?
You would imagine, and I hope my patients aren't listening to this, but you would imagine
I doubt it.
that I have a throughput of very wealthy, high dental IQ patients. And in fact, that's not the case. I have a very polarized list. So most people, I guess, in a general practice, treat everything from kids right through to seniors, you know, everything from fissure sealants to complete dentures, et cetera, et cetera.
Yeah.
Mine is mainly two groups. Group one is young people. By young, I mean younger than me, below 30, let's say. And they typically come to me for bonding only. Now, the odd one of those may have such a severe problem that we do ceramic. But the vast majority come for direct resin, either commonly single unit, actually, discolored tooth, or it just, their dentist just can't nail an incisal edge that's got a lot of opalescence or whatever. And they're aesthetically discerning, or multiple units. And the other group are usually people of above 60, 65. And they come for essentially rehabs. Now, that may be something as simple as an upper complete denture, bit of lower bonding, and a lower removable partial. That's quite a common case. Or it may be a mouthful of crowns on implants with endo and periodontal surgery. But generally, they're full mouth cases on the whole, or staged full mouth cases. So I don't treat much in between. But I wouldn't have thought, I think the younger patients, because of the fees and because of the office, are, yeah, I guess they're high dental IQ and actually extremely discerning. The older patients are usually, that's unfair. A large number of the older patients are actually lower dental IQ, and that's why they're in the shape they are.
That makes sense.
I'm not suggesting those people are lower IQ full stop, because often the classic one is an extremely successful, and it's usually a guy, extremely successful guy who's spent, I don't know, 15, 20 years building his business to the exclusion of his own health, and then 20 years running that business to the exclusion of his own health. And then he retires and thinks, man, look at the state of my teeth. And then they come for the dentistry they should have had 35 years ago, which is where we are. So yeah, it's an interesting, and the nice thing is you meet a lot of really interesting people because of that background. You know, I treat a guy who used to have a factory making washers for taps. I mean, how weird is that?
a very niche market.
Slightly, yeah. And then I treat people who are university academics and blah, blah, blah. You treat and I treat a lot of dentists, which is also interesting.
One of the highest compliments, though, I think, when dentists seek other dentists and they're discerning, they know.
They do. And actually, I think a lot of dentists don't like to treat other dentists, but actually another dentist is my ideal patient because, oftentimes they know what they need doing.
Yeah.
And it's
they should be a good patient, but
it does take a little bit of fun out of the communication element of it, the kind of mutual learning and the way we kind of present treatment. But in a way, it's particularly if it's quite challenging, it's quite fun to treat dentists. Yeah.
I have a question for you. So if you're sitting in front of a patient with a treatment plan and the discussion is some type of anterior restorations and the choice is between resin or indirect, and money is no object, can you review with me risk benefits of choosing one material and type of procedure over the other? How would that conversation go with your patient?
Yeah, so it depends why I'm restoring the front teeth. Now, if it were a class 4 restoration, for example, which is probably our most common anterior restoration, I would be looking at, does the patient have any aesthetic issues with the other teeth, right? Or did they fall and just smash one central incisor, which is quite common. And if they had problems with the other teeth, for example, they were an older patient and they'd lost volume, or they were small enamel fractures, or a bit discolored, or blah, 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 I would most likely do ceramic. And if they were, for example, a younger patient who'd fallen and smashed a front tooth, I would probably do composite. And the reason for that is if I do composite resin, I don't have to prep the tooth at all. Right, so that's cool. The other scenarios may be, for example, a peg lateral. Now, if we get a peg lateral patient and it's what I call conoid, in other words, it's wider at the neck of the tooth than at the incisal edge, it's a cone, and it's not in occlusion, then I'm probably going to encourage that patient to have ceramic, because I can just basically put a retraction cord and take an impression of it. The lab technician can reconstruct the palatal and the facial. The patient comes back and I just bond it in place, done. And I've reconstructed their guidance, I've reconstructed the palatal, and I've reconstructed the facial. Discolored teeth, they're kind of interesting. I did my general rule is with a discolored tooth, my first port of call is bleaching, usually internal bleaching if it's non-vital. But if it doesn't respond to bleaching, and quite a lot do, I'm probably going to go ceramic as my first option. And the reason for that is you get a better masking ability with ceramic. Therefore, you can do less prep. So actually, in that scenario, ceramic is more conservative than composite, which you wouldn't really consider. However, if your listeners are listening, there's a case I did on Facebook earlier on this week, which is 2 central incisors which are discolored, and I actually that was on a dentist. And I had this discussion with her, and she said, "Well, I accept all that, but I actually want you to do it in resin." Okay, fine. That's kind of what I'm known for. So that's cool. And when I was doing it, because I live in the southwest of England and she's from the middle of Scotland. So she's got like a 7-hour journey to get there, maybe 8. I'd done the treatment planning in a Zoom and also, via photographs, good quality photographs. And she sent me models and predicals. But when I started the case, I looked at it and the adjacent teeth had a really strong but quite unusual shape to the opalescence of the blue on the incisal edge. And she also had some deeper white hypocalcifications in her natural teeth, which were not especially obvious in the photographs she sent me. They're quite difficult to pick up in the photographs. And actually, as I started doing the case, I was like, man, I'm glad that I did this direct, because to communicate that with the technician, even though Paul, my technician, is on site, and for him to produce that could be quite challenging. Whereas I had the ability in the chair I got it wrong twice, actually, and I cut it off and started again, just the white bits. And it gave me the ability to kind of customize it in her mouth, which was a really cool and nice, neat way of doing it. And she's got an outcome I would suggest is as good as, 95% of the dental population would get with ceramics. Diastema closure is another scenario. I generally think diastema closure is better done with resin. And the reason is it's a no prep.
Yeah.
The only time I might think about doing it with ceramics is if the central incisors needed, in inverted commas, veneers in any case, loss of length, loss of volume, etc., etc. There are some people that suggest you can do partial veneers for diastema closure. In other words, it doesn't cover the whole of the facial. Yeah, you can, but it's quite technically demanding for the lab and extremely technically demanding in the chair to fit and polish down. So again, that would be a composite resin case for me. The other times, wear is the other option, the other scenario. In a wear scenario, it very much depends on the age of the patient. That's my overriding. And what I'm looking at there is the restorative cycle. In other words, how long are they likely to live? And
valid.
And how, none of us know how long we're going to live, but you have an idea on average. And how many times is that going to need to be replaced in their life? So, and what is the impact of me doing a procedure on that patient in terms of longevity of their tooth, not the restoration? So for that reason, if I see a young person with wear, and that's, I don't know about the US, but that's becoming way more common in the UK. And I don't quite know why, but I'm seeing a lot more TSL2 surface loss in what I would consider to be kids in their late teens than I used to in the mid-90s when I first started. Anyway, in those cases, I'm most likely going to treat them in resin. In an older senior patient who may be, 70, 80, if I'm treating an 80-year-old, I'm thinking, well, if my crowns last 15 years, that's about right. And by the time they're done with those, then, with a few exceptions, they're kind of done. So, yeah, that's kind of how my mind works, really.
Do you think there's a difference in longevity and color stability over time?
Yeah, this is an interesting one. I think historically, when we were using microhybrid composite resins, I think they were a little less color stable and they certainly picked up stain more. Mm-hmm. However, I think now with modern technology, when we're using nano-type composite resins, I think potentially the longevity of a resin veneer is the same as a ceramic veneer, right? And I'll tell you why. Composite resin veneers, particularly in the US, are seen as an interim solution. We do composite resin veneers while they can either afford ceramic veneers or as a staging procedure. And I don't think that's correct. I think if you look at the failure modality, in other words, how they fall apart, resin veneers tend to lose polish. they tend to become more matte and they tend to stain up on the facial surface as a whole. Ceramic veneers do one of two things. They either cohesively fracture, they break as a result of the occlusion, usually, or they stain at the margins, one or the other, right? Now, historically, composite resin veneers used to stain up at about the 5 to 6 year mark, and ceramic veneers, this is in my office, and ceramic veneers used to stain at the margins at somewhere about a 10 to 12 year mark on average. But the reason why composite veneers on the facial stain up significantly is because we have in composite something what's called an acquired polish and an inherent polish. So an inherent polish is the level of polish which will be on the composite resin when it's been in the patient's mouth, depending on the resin, for somewhere between 6 and 22 months. All right. It's the lowest level of polish it drops down to. An acquired polish is the highest level of polish that you can achieve as an operator or a dentist when you finish polishing, at the point the patient leaves the chair. The way to make composite resin veneers durable is to keep them in the acquired polish level for as long a period as possible. Now, we as a profession, on the whole, and I'm not criticizing anybody actually, this is just an observation. We don't take the patient to full acquired polish generally. Most dentists spend a lot of time, doing the layering and the mock-up, etc., and then the polish is just a quick buff over so it's not rough on the patient's tongue. That's average.
Right.
If you put a bit more work into it, what you can achieve is, rather than something that's a little bit buffed up and it doesn't feel rough, you can achieve something that actually looks like enamel, right? And that's far less likely to pick up stain, and that's called the acquired polish. Now, obviously, when the patient goes out of the operatory, they're going to do annoying things like use alcohol and mouthwashes and brush with abrasive toothpaste and drink wine and champagne and fizzy drinks, etc., etc. And because we're human beings, and that drops the acquired back down to the inherent, depending on, in terms of speed, depending on the lifestyle. But wouldn't it be cool? And this is what we do and have done for about 15 years now. If the patient came back for their hygiene recall, and rather than them getting a prophy, they got a polish with aluminium oxide polishing paste of the veneers, right? The rest of the tooth have a scale and polish, root planing if necessary, but the veneered teeth get a buff with, we tend to use a flexi buff from Cosmodent, an enamelized polishing paste, which again is Cosmodent. And the hygienist cannot do any damage with that. But what they do is raise from inherent to acquired polish on a 6-monthly basis. So that means the patient is staying in acquired polish for much, much longer, for as long as they keep coming back for hygiene. And that's really cool, actually, because it helps your hygiene book. Because if you say to the patient, look, it's... The analogy I make is if I do them for women or even for men, I say it's kind of like when you have your hair bleached or dyed, it looks great. And then after, 6 months, well, not 6 months, but with hair, a few months, it doesn't look great anymore. And you need to go back for a touch-up. And so I'd advise you to come back and see our hygienist. And in the normal hygiene recall, because our hygienist is female, she will polish those teeth and keep them absolutely immaculate for you. And in that way, your composite resin veneers will last probably twice as long. So that's great because the patient is then doing something which is for their own benefit, we're keeping our hygiene recall book really busy, which is great for us as a business. And as a business, you can choose how you want to invoice for that. I have some friends in the US who invoice it as a separate procedure, so it could be profitable. We don't do that. We include it in our hygiene because we feel it kind of gives buy-in to our hygiene.
Yeah.
It's a philosophical thing that I don't think there's any right or wrong, but it's just a win-win. Which is
I love that suggestion for several reasons. One, it's that great risk benefit conversation of nothing lasts forever, and there's maintenance required for any procedure that a dentist does. And so I think you're setting really nice, realistic expectations with patients, which most of us as dentists struggle to manage on a day-to-day basis. You know, you did this for veneer for me 20 years ago and it just broke. What kind of shoddy work? What kind of shoddy work is this? You know, so I love that you're having that conversation. And again, there's, you know, an inherent buy-in from the patient too, that they're coming back to see you on recare. And I would imagine it also means that you're getting great visualization on your work consistently and touch-ups and doing whatever you need to do to prevent the catastrophic failures that come along with doing this.
And, you know, even I did a nice case about 2 years ago for quite a young guy. He's only 19. He comes along to our office actually to flirt with my assistant. But anyway, but I just watch and smile for that.
Yeah.
But, and he had wear, and then he broke one because he wasn't wearing his night guard, and it was a simple fix in half an hour and a repolish, and he's back in recare. Had that been a ceramic veneer, it would be a relatively simple fix, but it would be 2 visits for starters. Take it off, and then we got the lab issue because, you know, as the ceramics in the mouth for a certain length of time with water absorption, etc., you know, it's not going to be the same shade. So we got the shade match issue, and we got the cost of the lab. Yeah. Whereas this was, he paid for it. You know, I invoiced him for it because he broke it. Yeah. But the cost wasn't crazy for a 19-year-old guy. It's 30 minutes of chair time. You know, just to rebuild this distal-incisal angle. And there we go. And we give them the models and we give them the stent with the mock-up and we give them the stent we've made. And nowadays, you know, I've always gave the patients the models, but it used to be a stone model and a wax up. And they bring the model back and it was like, man, where did you keep this? But, you know, nowadays with the, you know, CAD-CAM and we give them a 3D printed model, there's not very much they can do to it to trash it. So, you know, you've got a worst case scenario, we can drag it off the computer anyway. Yeah. So
is that your typical pre-workup, is some type of wax up, mock up, either digitally or from an analog, and using a putty matrix, Essex? What's your transfer?
Yeah, so my workflow is typically scan, digital mock-up, printed model. The exception to that is wear cases. If I'm going to do a wear case or tooth surface loss case, I'm probably going to do it old school with stone models and an articulator. Yeah. I don't have full buy-in to the digital articulator yet. I think it will come, and I hope it will come in the very near future, but I just don't feel it's there yet. And then from that, we make a putty stent on the palatal, trim that, and then take it to the mouth. That's usually the best way to do it. I know some people do it freehand, and that's fine. I just don't find I have the level of control to do that.
Well, and I mean, if you're going to spend all that time working it up, either digitally, surely you can take some of that information to make your life just a little bit easier chairside, right?
Well, it saves you a lot of adjustment time as well. And also, if we're doing major length changes, what I will tend to do is, as well as a putty stent, I will make a stent that goes over the facial as well. And then prior to anesthetizing them, we can just fill that with something like, I don't know, Luxatemp or something of this, and we can do a mock-up in the mouth and just make sure they've got buy-in for that length change. And we get the phonetics right, which is another issue, which you can't really assess unless you've got a mock-up. But they tend to be a little bit more complex cases, so you can build that into the fee. I generally wouldn't do that for a single class 4.
Yeah.
But for a wear case where we're increasing length 2, 3, 4 millimeters, then I'd probably do that.
So very technical question on that particular scenario where you're doing your chairside mock-up. In a case where it is going to convert to an indirect restoration and preparation is going to be required, do you still do that putty matrix, even though it's going to be slightly bulkier because you haven't fully done reduction yet because you want buy-in for the length and aesthetic?
Yeah. My general philosophy, it's very rare that I do veneers to bring teeth palatally.
Right.
That's very unusual for me. In other words, I'm usually doing additive dentistry. Mm-hmm. I'm not going to put my hand on my heart and say I'm a saint and I never prep away sound tooth tissue to make somebody happy because they won't do ortho. I'm some kind of ortho Nazi. But on the whole, 99% of the time it's additive. So I can add to the teeth with the mock-up and the patient can get a good idea. If potentially I need to do subtractive dentistry, I'm probably going to take them down the ortho route. So then that's not a big deal. One thing I would say about trying a mock-up is if I'm just doing it kind of for a basic case like composite resin, or if I'm doing it for myself to work out phonetics, I tend to use an acrylic temporary crown and bridge material because it's quick and cheap.
Yep.
If I'm doing it because let's call it I'm not really into sales, but let's say as a sales tool to convince the patient to have it done, or they're in two minds. Or another scenario is if a third party is paying, I will tend to make the putty stent not in putty, but in clear PVS, something like Memosil from Colza, or RSVP from Cosmodent, or GC have one as well. And I would tend to do the mock-up in composite resin, flowable, but I would suggest, it sounds like you might want to use the enamel shades to do the mock-up because you're kind of replacing mainly enamel. Trouble is, if you do that, it's quite translucent and you see the tooth structure underneath, and actually the mock-up looks a bit gray. And unless you're working with a dentist or somebody in the dental profession, dental technician perhaps, all they can see is gray, and they're thinking, man, I don't want to have this done. I'm going to end up with gray teeth. They're not looking at the shape and form and length. So I would suggest, if you're going to do that, to use a dentine shade or opaque, some companies call it.
Okay.
And also make it about one shade lighter than their teeth, right, in the mock-up. Not in the finals, but in the mock-up. And in my experience, that's just been more successful because the patients, they're like, wow, the teeth are whiter. That's cool. They don't look worn. I can't see the tooth through them. And that enables them then to focus on the length and form of the teeth. It's a small tip, but
I like that.
It's quite important. I've lost cases from using the wrong material to mock up.
Yeah, you're right, because they have to still be somewhat visionary to appreciate that there's limitations still in a mock-up. It won't be the ideal layering techniques. And
if you kind of sell it to them on the basis of, look, we're going to do a mock-up, and then if you love it, we'll go ahead. And then you try to mock up in the mouth and it's gray and there are visible margins, and you start saying things like, well, it'll be a lot better in the finals, trust me, which is what I used to do.
Yeah,
As a
obviously something I may have
consumer,
said this
I
week.
would be,
Yeah.
if somebody did that to me, I'd be like, man, he can't do this. This is
Mm-hmm.
going to be a disaster. I'm not spending my hard-earned money on this. It's garbage. So I'll live with what I've got. So yeah, it's just a thought.
Yeah. All right. Tell me top 3 mistakes that dentists are currently making, either in aesthetic dentistry or adhesive dentistry.
All right. So we spend a lot of time in CE learning about layering, right?
Mm-hmm.
Which composite shades to use, which translucencies, which opacities to use. And actually, in my view, that's perhaps the least important thing, right? The fall down in general dentistry for doing direct resin, be it class 2, which is the most common one we do, or class 4, which is also a very common one, is basic operative. We fall down at basic operative. So we take a burr and we remove the old amalgam or remove the old composite resin. Now, typically we'd be using a high-speed handpiece for that, and we'd be using a medium or coarse grit diamond or carbide because it's efficient, and that's quite valid. The trouble is, if you use a medium or coarse grit, it chips the enamel prisms at the margin at the same time. So if you look at them under electron microscope, you can see all the enamels all crazed up. And then most dentists at that point will just place some etch, prime and bond, and place a composite resin. As the composite resin polymerizes, it shrinks. As it shrinks, it creates stresses. And what happens is that the chipped the chipped enamel at the margins rips away from the main body of enamel. We call that enamel peel. Then you get a white line.
Mm-hmm.
And then the dentist says, oh man, I'm getting white lines all the time. They go online and they say, I'm getting white lines in my composite resin. What can I do about it? And some genius who's trying to sell them some product starts to say, it's your bonding agent. You need to change bonding agents. And they change bonding agents, still get white lines. It's a basic operative problem. So the solution actually is, once you've done that, to take a carbide. Carbide is better than diamond. You can use a fine diamond if you wish, but carbide is best. At extremely low speed, 3,000 to 5,000 RPM, with a water spray, and go around the margins and finish the margins. Just like you would do, like you wouldn't send margins like that to your lab if you were doing an inlay, because it would be embarrassing, because your lab would look at it and think, what a monkey of a dentist. They can't make a crisp margin. And yet we don't do it with directs.
Uh-huh.
And it would make a huge difference. So that's one mistake. The other mistake is, and this is becoming more well known now, all teeth have biofilm on them. All teeth have what's called an aprismatic layer, which by definition, the enamel has no prism structure, therefore it doesn't etch well.
Mm-hmm.
Very few dentists actually remove it, and most dentists try to bond to it. Right? So if you try and bond to biofilm and you try and bond to aprismatic enamel, your net result is a white line. Right? So why not just do some air abrasion? Yeah. Particle abrasion is a better term for it, because it's not the air that abrades it, it's the particles. But anyway.
Valid point.
Yeah. With a small particle, 27, 29 micron alumina, 2 to 3 bar. Remove all that garbage, get a much higher bond strength, don't get a white line.
Love that.
That's the second tip. The third tip is polish anteriors and posteriors until you get the full acquired polish. And then you're going to get durability. And particularly on posteriors, I've just actually filmed a video on this for Spear, which we're just editing at the moment. Finish at a butt margin, and make sure when you do don't finish on a bevel, on the occlusal, which may sound surprising because I know a lot of people teach bevels. Mm-hmm. There's no advantage to cutting a bevel on the occlusal. There are significant disadvantages. The obvious disadvantage is you've got a thin flash of composite resin, which if you occlude on it, it's going to break off and give you ditching. Even if you don't occlude on it as you occlude on the main composite resin restoration, the class 1 or class 2, you've got energy from the muscles of mastication going through the teeth, and the energy's got to go somewhere. Now, it goes out to the dentine and through the periodontal ligament into the bone. But as the energy dissipates, that thin area of flash is a site for energy concentration. It's called a stress riser in engineering. And that is going to make that area chip off, even if you don't occlude on it. That's why you get palatal chips on upper premolar and molar teeth, even though you haven't got dynamic occlusion in that area. It's absorption of energy, particularly in premolars, because there's not a lot of tooth to absorb the energy. So it's mainly being taken by the composite resin. Mm-hmm. The other reasons are it's more difficult to adjust the occlusion because you just bird a bunch of it away.
That's lucky.
And, it stains up more. So for that reason, I've finished the occlusal to a butt margin. So
and then polish.
Yeah, they're my 3 tips. Make your life simple. And, get a good acquired polish. Do good operative in terms of removing biofilm, removing aprismatic enamel. And get rid of chipped enamel prisms at the margins with margin finishing. If you don't want to do that, your other option is to move offices every 2 years.
We call that geographic success. Yeah, exactly. Well, that's a 4th tip. We must include that.
Works for some people.
Yeah, I know. I know. Where can people find your videos? Where can they see you lecturing? Are you at Spear pretty frequently? What's your accessibility?
So I have my own website called Restorative Program, which is spelled in the English way, ME.co.uk. It's an English website. And on that, we have details of my live courses in the UK, if you wanted to travel to the UK. And we also have a very comprehensive video series of pretty much all adhesive operative dentistry in terms of lectures and also in terms of live demonstrations, which are view on demand. I think it's fair to say it's one of the larger collections of operative by one person that is around. There's about 120 hours, roughly, in 3-hour segments. Then, in terms of live stateside, I'm at Spear 3 times a year. So, when's my next Spear? September this year and November of this year. I do a comprehensive 3-day resin class. So that covers everything from class 2 through to class 4, diastema closure, peg lateral, discolored tooth and wear, all over 3 days. It's pretty hard course, but we've had really good feedback from that, in so much as, you really move on in terms of your resin skills if you just do it intensely for 3 days. Mm-hmm. And I also have upcoming in July a 2-day class in Chicago with Cosmodent. And that is what I would call a foundation class. I would not say it's basic, but it's on 1 day on posterior resin, multiple ways of doing posterior resin, and 1 day doing 2 class 4s, one with a very simple approach, which might be useful for, insurance-based dentistry, which is realistic. We all do it, or most of us. And then another way doing a kind of super-duper high-flying class 4. And that's unusual in the US because it's what we call blended learning. So it means you don't go into the class and sit and listen to watch a lecture, because I think that's a little bit of a waste of time. Mm-hmm. The lecture is recorded, pre-recorded, and then the 2 days is all hands-on. So you're essentially getting 3 days in 2, so you have to have 2 days out of the office. So that's me stateside.
Well, I really prefer the blended learning styles, especially for techniques like this. We really need application and feedback from the instructor. So, and I think your points are really valid too, that insurance-based dentistry, I mean, the current economic climate, probably not just unique in the US. I think clinicians are really going to have to expand their horizons a little bit on adhesive dentistry, because you brought up a point that often that's more economical and more approachable for more patients.
Yeah.
And, that may be what we're leaning heavier on over the next couple of years as we sort
You
of
may
ride this
find,
wave.
interestingly, the dentists I treat who are usually relatively affluent, and they know what they want. They usually go down the resin route because it's more conservative.
Yeah.
I treated a guy who's on TV, actually. I won't name him. And he's on TV doing 10 ceramic veneers every week. Guess what he had?
He knows.
Well, I said to him, "Are we gonna?" I was joking with him. I was like, "Are we gonna do ceramics here? Because that's kind of what you like to do, isn't it?" He goes, "No, what?
Is that the old adage, do as I say, not as I do? Yeah.
Yeah, exactly.
Yeah.
Yeah.
Thank you so much for taking your time away from your garden to spend with me and with our audience. I've learned so much from talking to you. I think as colleagues and professionals, the learning never ends. And I'm in a fortunate position that I get to dedicate time to honing my craft as well with some really fantastic educators.
Cool.
So really appreciate it.
Excellent. Have a good weekend.
Thanks. You too.
All
Take
right.
care. Bye, everybody.
Bye-bye.